So, hi, Angelo. Welcome to the Big Unlock podcast. We are so happy to host you, and thank you for sparing the time to join us today.
Well, thank you, Rohit and Ritu. This is an absolute pleasure. I was so delighted to be invited. I've had a chance to listen to some of your episodes, and you have a fantastic program, and it's an honor to be part of what you're doing here.
Thank you. That's awesome. So, I'll do a quick intro from my side, Angelo, and I'll let Ritu do hers, and then we would hand it over to you. Please do as detailed intro as you would like, and then we'll chime in with some questions as well. So, I'm Rohit Mahajan. I'm the managing partner and CEO at Demo Consulting and at Big Rio, and also the co-host of the Big Unlock podcast here. So, over to you, Ritu.
Thank you, Rohit. Dr. Angelo, welcome to the podcast. Absolute pleasure having you here. My name is Ritu M. Oberoi, and I'm also the managing partner at Big Rio and Demo Consulting, and also a co-host of the Big Unlock podcast. And we're looking forward to an invigorating discussion today. Thank you.
Well, thank you again both for the invitation and the opportunity to speak with you today. I really like what you're doing with this show. I think it is speaking to issues that are so important right now in healthcare, in innovation, in healthcare management. So it's a tremendous pleasure. I can tell you a little bit about who I am and what I do, and then we can jump deeper into the conversation. But my name is Angelo Milazzo. I am trained as a pediatric cardiologist and still spend a little less than half of my time in clinical practice. And my clinical practice includes patients from prenatal life all the way through to adulthood who have primarily congenital forms of cardiac disease, but also acquired forms of cardiac disease. And my clinical practice keeps me very busy. It's a very interesting field. It's a field where we have many applications of technology, which I think are really interesting. It's a field that includes some procedural medicine, some diagnostic medicine, and we work very closely with other specialists, including surgeons and anesthesiologists and critical care physicians. So it really is a fantastic type of clinical practice, and it's one that many people may not be familiar with, but is a really important part of what we do in the realm of children's healthcare. The other part of my work is as an administrator. So I am the chief medical officer for what we call the Duke Health Integrated Practice. So I am here at Duke University Health System, which is based in Durham, North Carolina. The Duke Health Integrated Practice, you can think of it as the faculty practice of our health system. It's actually a bit more than that. We have about 4,200 physicians and advanced practice providers. So our nurse practitioners and physician assistants are counted within the faculty practice as an important part of what we do. And we really are the specialty practice of the health system. We have another organization that manages primary care as their primary book of business, no pun intended, primary care, primary book of business. So that is not part of my purview, but I work very closely with that organization. That organization has its own chief medical officer. But I'm the chief medical officer that interacts with our 18 clinical departments, everything from pediatrics to internal medicine to OBGYN to radiology to surgery to dermatology, et cetera. And I help to develop strategy primarily for our ambulatory platform and also implement and operationalize clinical innovation, procedures that help us improve access, that help us open up our door, so to speak, to new patient populations, to new areas of practice, whether it's medical or surgical or diagnostic or procedural. So I have a broad responsibility here and a broad engagement. And I think the final thing I would say is that, our health system is associated with obviously Duke School of Medicine, which is, a fantastic medical school, always considered a top-tier medical school. So we have a very significant mission around education, around training, around research, and around advocacy, and all those functions are directly connected to the clinical mission. So everywhere we practice medicine, we also want to innovate, we want to do research, we want to teach, we want to educate, and we want to advocate as well. So even though my role is primarily a clinical leadership role, I get to work with other leaders in all those other areas, which makes my job really multifaceted and really exciting.
That's awesome. Yeah, thank you for that introduction, Angelo. It's been quite a journey for you. You've been with this health system for a long time. So, would you like to share your journey with the audience? Like, how did you get started? What interested you? And what are some of the new things that you're working on? And also talk to us a little bit about the patient population in the local area.
Sure. No, I'd be happy to. So, in terms of my journey into healthcare and healthcare administration, it actually started quite early. When I was finishing up my fellowship training, I was offered the opportunity to build a branch of our academic pediatric cardiology practice away from the mothership, so to speak, so to build essentially a large satellite office. So very soon in my career, I got involved in practice building, practice management, and healthcare administration. Within about a year, I took over the medical directorship of this practice, and over the course of about 10 years, grew the practice from a very small operation with just a couple of physicians seeing, a few dozen patients a week to what is now a very large multi-specialty practice that has about 3 dozen medical and surgical specialists that come in and out of our doors, seeing thousands of patients a week.
Right.
Very proud to have been part of this project from its initiation, from its conception, and through its phases of growth. Along the way, I had a very significant hands-on training with executive leadership, with management, and also with day-to-day clinical operations, which became an area of interest to me. I was eventually offered the opportunity to take on a new role, and that role was as the um, vice chairman for clinical practice for the Department of Pediatrics. And in that role, I took what I had learned at the local practice level and brought it to an entire department
Nice.
and became the operational and strategic leader for everything we do in our Department of Pediatrics, which includes about 250 or so clinical faculty, another 50 or so research faculty, primary care, specialty care, diagnostic care, urgent care, emergent care, inpatient, outpatient, all the
Wow.
different aspects of our care. And did that work for a little less than a decade. And I'm actually moving away from that role now because last year I stepped into yet another role as the chief medical officer for the
Right.
health integrated practice. So I've been in that role now for a few months, and I hit the ground running when I took on the role. Immediately, as in my first day on the job, had to help with some challenges, things that we're going through as an organization. And it's been very exciting in just these first few months to begin to see the opportunities that I will have in terms of, you asked about some of the things that we're working on, and we're
You're
going
right.
to talk today about some clinical innovation, and that's been extremely exciting to work on.
That's awesome. Yeah, so that leads us right into our next, topic is that what are some of the clinical innovations or some of the challenges that you faced that you were able to overcome, and what are some of the digital health, programs that you're getting involved with, anything that you would like to talk more in detail and share the story on that.
Yeah, fantastic question. So my first day on the job, I had to address the audience of our entire practice, all the clinical leaders from across the health system. And I told them that I saw my role as chief medical officer as being one who was there to support clinicians in their
Mm.
day-to-day work. So my platform rested on the idea that I want to bring aid, I want to bring tools, I want to bring tactics into the practice that actually help people do their work. In the last few years, we've been facing issues with challenges in the workforce, people feeling burned out with their work, people feeling disillusioned with their work, people feeling like cogs in a machine. I want to bring the joy back into the
Yeah.
practice. And I think the way to do that is to allow physicians and other clinical providers or other clinicians to spend as much time treating patients as they can. So we've identified some areas of the work where we can innovate, where we can bring technology to bear to actually improve the experience of delivering care for our doctors, for our nurse practitioners, for our physician assistants and other clinical personnel. So one thing we've done, something very concrete, we've done this in partnership with a very innovative healthcare technology organization, is we have applied what is called ambient listening technology. And we've done this in a way that has, I think, been thoughtful, in a way that has been in response to the problem at hand. That is, how can we alleviate our clinical providers of some of the burden, in this
Mhm.
case, the burden of documentation.
Yes.
We know that physicians and other clinical providers today spend a lot of time in front of a computer, often while they're in the room with the patient.
Yes.
We know that this has the tendency to make people feel like their job is data entry. We don't want the job to be data entry. We want the job to be managing patients. We want the job to be engaging, spending that face-to-face time, because we know that so much of diagnosis is made just from the history, just from
Mhm.
having an in-depth conversation with a patient and hearing about their problem. Yes, we can do a lot of fancy things with diagnostic testing, but at the end of the day, it's about the engagement with the patient. That's where we learn about the differential diagnosis, and that's how we begin to build a case for our assessment and our plan. So what we've done is we've brought this ambient listening technology into the encounter, into the clinical space. And this tool is recording the conversation between the clinical provider and the patient, and then taking that information that comes from that back and forth, and from it creating the encounter documentation. And it seems like such a simple variation of the standard tape recorder that goes to a human scribe, or even bringing a human scribe into the room
Yeah.
and having them listen to the encounter and having them generate the note. But this is truly the modern version of that.
Right.
The conversation is filtered, and we can get more into the actual procedure, but it's filtered through a natural language processing algorithm. And
Mhm.
then what you get, the finished product, is something that very much is usable as clinical documentation. So this has been a very exciting opportunity for us to leverage this technology at the point of care to
Mm.
take away some of that documentation burden.
And that's a great use case. It's actually one of the hottest ones that we are seeing in many health systems, Angelo. So tell us a little bit more on how did you, you talked about some metrics before we started the podcast. So how do you measure this success of this, this wide scale implementation, as you mentioned? And second, you also said it's integrated with the EMR, EHR system. So I think these two are core for people who are, still thinking about this. Many have already taken the plunge with various degrees of success, but you've seemed to kind of embrace it and roll it out to a much wider audience. So
Yeah, so
any learnings or,
it's a
impressions?
fantastic, oh, sorry, go ahead.
No, I was just saying any key takeaways from your, entire experience that you think were very instrumental. Yeah.
Yeah, these are fantastic questions. So thank you for them. I would start by saying that the the pre-implementation data that we were looking at were both qualitative and quantitative.
Mhm.
From a qualitative perspective, it was quite literally hearing from our faculty, from our doctors, from our nurse practitioners, from our other clinical providers, hearing that they were losing the joy of the work, the joy of practice.
Mm.
Mhm.
These are folks that, as you know, have spent a lot of time and they've invested a lot. There's been a huge opportunity cost to getting trained, to becoming, clinical providers, and they want to practice their trade. They want to engage with patients. They want to have that interaction, which is such a special opportunity for us. And what we've done over the last several years is we've created the opportunity for them to feel less and less connected to the actual work because we've built these amazing electronic health record systems which require a ton of digital inputs, right? They require the clinician to spend a lot of time typing, to check a lot of boxes, to click through a lot of screens. We've also, at the same time, opened the door to our patients to engage with us outside of the visit. So now not only are they having to deal with patients at the point of care, they're also having to answer requests that patients send after hours. They're having to do telemedicine and telehealth visits, which are amazing, but also another threat to their well-being, right? So it starts with the qualitative data. Are our people enjoying their practice? Because if they're not, then we have a problem. We know that there were workforce challenges. We know that during the pandemic, a lot of physicians left the workforce, a lot of nurses left the workforce. We need countermeasures against that. In terms of the qualitative data, we have a number of things to look at. We have what are called signal data. These are data that tell us about the engagement of our people with the electronic health record system. Tells us when they're logging in, quite literally what time of the day are they logging in, how much time are they spending, how well are they doing with basic tasks like responding to inbound messages, how long is it taking them to close their notes, is it being done within a certain number of business days, is it being done in a way that satisfies patients' expectations. So the other quantitative data we have are the provider ratings that we generate. And we ask questions like, did your clinical provider listen to you? Did your clinical provider know your history when you showed up? Did your clinical provider speak to you in a way that you understood clearly? Did your clinical provider explain things in a way that was satisfactory? So those are data, I think, that bridge between qualitative and quantitative,
Yes.
but they are still numerical data where we could look and say, okay, this provider does not have a great rating. We need to drill deeper into it and figure out why. And in many cases, when we ask providers about it, they would say, I just don't have enough time with my patients.
Yeah.
And it's not just about the length of the visit or the length of the encounter, it's about the quality of it too. Um, so, those are some of the pre-implementation metrics that we have looked at. The other thing I will say, in terms of the way we went about this project is, we brought our data performance engineers to the practices. And that is a theme that I feel really, really strongly about. We have an amazing, we call them performance excellent engineers or performance engineers. We have some amazingly talented people who know how to collect data and they know how to translate data into information. But in the last few years, so many of these people have been working either from a centralized office or worked from home, and it's not their fault. It's what we've required them to do. I have found, and we have found, that when you take these folks and bring them to the point of care, whether it's the operating room, whether it's the emergency department, whether it's the primary care clinical office, whether it's the endoscopy suite, that's how they really begin to understand the work.
That's true.
And that's when they can help us, again, translate practice data into actionable information. So that's been, and this is something that this is business school 101, right? The Toyota production system, you bring people
Yeah.
who are doing the work, you utilize their expertise to tell you how to do performance improvement. We had gotten away from that a little bit, and now we're getting back to it, and we're seeing the benefits.
That's awesome.
So, Dr. Angelo, I was at a conference recently, and Abridge, who's one of the main players in the ambient, said that they had reached the level where 81% of the notes did not have to be edited by doctors, and that was leading to huge satisfaction. So, are you seeing those kind of numbers, or do you think
Yeah,
that
Ritu, this is a very interesting question. And it's interesting for a number of reasons. First of all, full disclosure, we are using a bridge. So that is
Okay,
our
great.
that is our partner in the space. And one thing that's been wonderful about that relationship is they have craved our feedback about the product and they want to iterate. And that's why they were such a natural partner for us because we share that DNA around innovation. They want that product to be getting better and better and better as we use it. To your comment about 80% of the notes not requiring editing, this is a really interesting data point that we are looking at. We're actually looking at the number of times notes do or do not get edited. And there's actually a
Right.
signal in both directions that we need to be careful about. We need to be careful about the people who never edit their notes,
Yes.
because that's one kind of story. And
Mhm.
we need to ask about the people who are always editing their notes. I can tell you that in my practice, and I have more than 20 years of clinical experience, and I'm somebody who likes his notes done a very specific way. I actually have been
Exactly.
quite happy with the quality of the content.
That's
And
great.
when I have edited, it has been
Yes.
primarily not to correct errors of fact, but just to
Mhm.
change the language to a style that fits more with my personal style. So
So,
it's really been more about the aesthetic of the note rather than the actual content of the note. I found the content to be quite good. And when it has not been good, this is the other nice thing about our, Rohit, you mentioned before that it is embedded in our EHR.
Mhm.
We can provide feedback immediately. So if I
Mm.
see a note that did not turn out the way I expected, we have a chat box. We can go right into it and we can talk right to the development team and say, this is why I don't like this note.
Oh, wow.
And
Okay.
we can also see the stems, the original stems of our conversation. And we can see how the natural language processing model created our note from the original stems. Um,
nice.
and again, having that direct pipeline to the developer has been critical. Just a few weeks ago, the Abridge team came to us. They did an extensive 2-day site visit. And again, they wanted to hear directly from us, directly from our doctors, directly from our clinical providers, how they were engaging with the technology, what was working, what was not working. Um, with very rare exception, most of our people have said this is, I hesitate to use the term game changer because everybody uses it.
Yeah.
It's almost become meaningless, but this has
Mhm.
been disruptive in the best possible way, right?
Right.
This
Really
has
good to
Yes,
Yeah.
this has enhanced our practice. I'm able to close my notes. I'm able to leave the office at the end of the day, not having to go home and, work after dinner or work while I'm wearing my pajamas or work while I'm doing something else, wanting to spend time with my kids or, taking me away from my hobbies and my interests. This is allowing me to close the books at the end of the day, feel
Mhm.
good about the quality of the content, and, really, again, so much of the upside is that ability to spend time. And we're going to be really interested to see that metric that we have, which is did your provider spend enough time with you? I'm going to be really interested to see how we improve on that metric
Yeah.
with the implementation of this technology.
Yeah. So in the same conversation, they also mentioned that some of their physicians are seeing rush hour traffic for the first time, which can be, good or bad, depending on how you look at it. So to your point of, that you're able to close the notes and go home, that's really good to know.
I think it is. And, one thing we really like about this technology is the modularity. So
Mhm.
you can use it for certain elements of your note and not other elements. You could use it for the entire note if you like. But that has helped adoption. So the
Great.
idea that, if you felt like you were really good at documentation and only wanted to use it for your history of present illness, you could use it that way.
Mhm.
And that's been nice. We have asked people to try it, and we have
Mhm.
almost, universally people have at least tried it. Most people who've tried it have stuck with it, and we have metrics around that. We know
Yes.
what percentage of people have only used it once. We know what percentage of people have used it for X percentage of their notes. And we are seeing a very, very nice, onboarding of the technology, so to speak. And, we're not close to the plateau yet. We're still in that ramping up phase, but it's been really exciting to see the adoption.
That's very,
Great.
yeah, shifting gears, I would like to, I know that we didn't, touch upon this yet, but uh, Angelo, what are your thoughts on value-based care? And is that something that, your practice is thinking about?
I think it's a very important
Hmm.
part of what we are wanting to do. I will tell you that in this part of the country, in the southeast part of the United States, In general, I think the move toward value-based models, bundled care, and similar models, I think the adoption rate has been slower in this part of the world.
Mhm.
When we look at our colleagues in the northeastern United States or the West Coast or other areas where folks have been very innovative in the space, very progressive, we are certainly trying. I think there's a number of reasons for that probably go beyond the scope of what we want to talk about today. Nevertheless, we are very excited about the opportunities to create efficiency of care, to reduce cost,
Mhm.
to bundle services together in a way that shows the value by, taking that good old formula of quality divided by cost of,
Mhm.
we think we are doing a great job with the numerator. Our quality is very, very high. Now
Mhm.
it's all about shrinking that denominator,
Mhm.
reducing the cost of care. And there are ways of doing this that may involve the application of technologies, but also may involve some analog solutions too. We're also interested, and we work really, really closely with the payers. We're interested in what they have to say.
Right.
And some of the work we've done in the last few years has been talking, having really strong bilateral relationships with the payers to determine what's on their radar in terms of their quality and performance metrics. Um, we also want our people who are delivering the care to tell us what's important. In some cases, that will align with what payers are saying. In other cases, it may not. When it doesn't align, we
Mhm.
have strong enough relationships where we feel as though we can go to payers and say, hey, we've talked to I'll just give you an example. We've talked to our pediatricians and they're really worried about adolescent immunization rates.
Mhm.
You may be focused on immunizations in the first year of life, or perhaps in older adults. Maybe it's meningococcal vaccine or pneumococcal vaccine or RSV vaccine for
Yeah.
senior citizens. But we are hearing from our folks that they're not getting their teenagers into the office for their pre-college immunizations. In
Yes.
most cases, the payers are at least willing to have that conversation.
Yeah.
We're also interested in how we can demonstrate the value proposition so that when employers come into our area, and
Mhm.
this part of the country is growing very, very fast.
Yeah.
We have many large employers who are setting up shop here in central North Carolina because of the three universities here, the amount of research that goes on here. We want to make sure that when employers offer a product that includes us, in
Mhm.
their network, that we can go to them and show the value because they're paying for these services. So whether it's hip replacement or organ transplant or even common things like primary care or
Mhm.
preventative care, we want to make sure that we can show them the value. And large academic systems have not always been at the forefront of being
Yeah.
able to contain cost, but we are learning. We are seeing where the opportunities are. And a lot of it is around clinical operations. There's a lot to be
Mhm.
gained in efficiency in clinical operations. And when you start to do those things, you really can drive down the cost.
That's awesome. Ritu, any follow-on questions?
Yeah, I would like to ask you about AI education and the trustworthiness of AI. Like, did you face any barriers from your physicians on those regards? Or because sometimes we've seen with physicians, they're reluctant to try new solutions. And there was this New York Times article which showed that when ChatGPT was doing the diagnosis on its own, it was much better. But when the physician came in, because they brought in, their own preconceptions and biases, it actually did worse because they did not trust the, AI and took it in a different direction. So how have you, made sure that everyone's educated and had like a certain context setting within your organization for such a wide rollout?
Again, fascinating question. We could spend a whole podcast on just this question.
Mhm.
So we have certainly needed to address this issue, but I must say that I have been pleasantly surprised that most of our clinical providers, physicians, advanced practice providers, physician assistants, they have asked questions, but in a very thoughtful way, not necessarily in a way that betrays a lot of hesitancy, more in a way that just shows that they are they're trying to keep pace with the developments in these areas. They're listening to these conversations and they want to make sure that we're good stewards of the technology. So yes, they have asked questions like, what are we doing with these recordings? Are we using patient information to improve the system? Are you using my information to, are we training the language models with our information?
Yes.
They have wanted to know things about how do you provide consent? How do you obtain informed consent? And we certainly, just so you know, we are certainly asking the permission of our patients every time we use this technology in every instance. Um,
Yes.
and so, they have probed around the edges. One thing I will say is we have a very robust structure here for digital innovation. We have several teams. We have a team that is just working on AI. So they have done yeoman's work in making sure that our faculty feel really educated with at least the basic terminology around artificial intelligence and natural language models and generalized AI and things of the sort. So I think most folks here feel as though they have amazing colleagues who are providing those educational materials. The other thing we did, and this is a huge shout out to my colleagues who ran the pilot, is before we implemented, we did a really, really well thought out pilot. And it was a crossover, so we tested a few technologies. And during that pilot, and we opened the pilot up to a large number of clinicians across the entire system from all different areas of the practice. That was a huge benefit because in that pilot phase, which went on for several weeks, they were able to give us feedback. And we solicited, we did a pre-pilot questionnaire, we did an intra-pilot questionnaire, we did one afterwards. We looked at the use of all the different technologies, what was good about one, what was good about the other. We used their direct feedback to tell us what they wanted in a finished product. And again, during that piloting phase, we did a lot of education. We had modules they could review. We had many town hall conversations. We went to all 18 of our clinical departments and answered questions. We had our data people, our technology folks, our IT specialists, our data analytics folks, always part of those conversations. And most of those folks are also doctors. That's another great thing
Exactly.
about our organization is most of our, if you want to say IT leaders, most of them are physicians too. And when you have that clinical practice perspective, it buys you so much credibility with your audience.
Yes.
That was a key piece, I think, to winning folks over.
Great. Thank you. That's an excellent answer. Thank you.
Yeah, so I'll chime in with another one, Angelo. We know that, and perhaps, and this is towards the end of our conversation here, on the podcast. Uh, we've all been hearing about agentic AI and that agents are, the next big wave from a Gen AI perspective. So any thoughts that you have around that? We are working with several of our clients on, defining and finding use cases for implementing agents in the workplace because they're talking about a new digital workforce, which includes humans and agents. So any thoughts about that?
It's an area that is going to be growing exponentially. We are right now testing the
Mm-hmm.
ability to utilize AI to screen inbound messages. So I mentioned before
Yeah.
that one of the pieces of fallout from our digital access, opening that digital door to our patients, is we're getting a tremendous number of inbound messages, thousands and thousands of messages per day. That's a good thing. We want our patients to communicate with us. We want them to access us, but it's a lot of work and it's real work. So we are working, we have a AI innovation research team that is looking at models that can not only review these messages, but sort them into categories.
Mm-hmm.
So being able to distinguish between a message that just says, thank you for the great care you gave me, and a
Yeah.
message that says, I need a prescription refill, or a message that says, I need an urgent appointment with my orthopedic surgeon. And
Yeah.
then the stage after that is not only sorting, but beginning to build at least the skeleton of an answer.
Yeah.
Um, and this is a really complicated problem to, it's complicated when humans do it.
Yeah. True.
But I think what's exciting about it is that we have people who recognize, again, kind of connecting back to what I talked about before, this is another way to alleviate our clinical teams from some of the, I'm going to call it clerical burden that they face today.
Mhm.
If we can pare down the messages to the
Mhm.
ones that really, really need humans
Yeah.
and carve away some of the other less value adding messages, they're still important,
Yeah.
but they're not as urgent. If we can triage this,
Yeah.
that alone will be helpful. And then if we can have some, and again, to your point, Rohit, I think it's going to be a synergy between
Mhm.
human capital and technology capital, right?
Mm.
If we can create a really nice synergy between the two, then maybe people don't lose their jobs. Maybe people take on new kinds of work, right?
Mhm. Yeah.
Absolutely.
That's the
Yeah.
future that I personally think we are headed toward. You know, I'm old enough to
All of us.
I think all of us remember the early days of the internet. I think all of us remember, you know, the doom and gloom stories. Um, what we have learned is that these tools, we need to approach these tools with an open mind and recognize that we can use them responsibly
Yeah.
if
Yes.
we want to, right? Um, it's about us figuring out the most responsible, the most applicable use case, and then being good stewards of the technology. Again, I am encouraged because so many people in the space who are applying these solutions to healthcare really do understand the practice of healthcare. So that's why we need these really close partnerships, like our partnership with the Bridge, or other institutions that have partnered with Copilot or with other technologies. When you have that strong clinical technologic partnership, you can do amazing things.
That's true. That's true. So, Ritu, as we are coming close to the, excuse me, close to the podcast, anything else you would like to ask, or we can ask Angelo for closing remarks?
I think so. I think we'll need another podcast to follow through
Yeah.
on more questions. Thank you for being a, great guest and giving us really good answers. And we would love to have some closing remarks from you. Thank
Yeah,
you.
I think you're, first of all, you're incredibly welcome. This was a fascinating conversation, and again, I love what you guys are doing with this show, and I hope at some point we can convene again. I would love to come back. I think in closing, you know, one thing I would leave the audience with is these feel like incredibly challenging times,
Mhm.
but we can do incredibly challenging things in response to incredibly challenging times. And sometimes um, that's the most amazing road towards success is when you are pressed, when you are facing obstacles. And, you know, these tools that we have at our disposal today have amazing potential. We just need to be really good stewards of that potential, really thoughtful stewards of that potential. We should not be afraid, but rather we should continue to ask these fundamental questions. And we should think of the future as being, again, a synergistic future where we take the best of our human capital, the best of our human talent, and we weld it on to this technological capital or this technological tool, this innovation, and we figure out, you know, the next step forward. So I actually see, I kind of believe in this idea of abundance, and think that we have a future of potentially great abundance. It's just going to be a matter of deciding the terms of that engagement with abundance. You know, how do we take the tremendous potential that these natural language models have, that general AI has, that these other technologies have? And how do we apply them in a way that's thoughtful, that's rational, that is done in a way that really speaks to the need of people who are trying to move these things forward? So you know, again, and in closing, I would say that in our case, we listened to what our people were telling us about their work, and we reasoned that the only way to really move forward is to change the work.
Yes.
We can be supportive, we can provide a shoulder to cry on, or you know, uh, an arm to hold in times of distress, but when we actually change the fundamental, pardon me, nature of the work, that's how we really begin to change people's engagement with the work and make them feel as though they're being supported, as though they have a clear way forward. Doctors are a resilient bunch. We don't lack resilience. What we need are tools to help us, come to the work by changing the terms of the engagement.
Great, great.
Great.
Awesome. On that note, Angelo, I'll click on closing the recording.
Thank you.
Thank you so much, and we can chat for a few minutes.